All right, so Dr. Sirigupa is actually one of our pediatric intensivists at here at CRMC, and he is an assistant professor of pediatrics at UCSF Fresno Medical Education Program. He actually did his residency at University of Florida College of Medicine and Shands Hospital, and then he did his fellowship in pediatric critical care at the University of Chicago, Pritzker School of Medicine, and Comer Children's Hospital. And then he decided to join us here in Fresno because I guess he didn't like the winter in Chicago. Just kidding. Hopefully, we can keep him here for a long time. He's a great intensivist. I worked with him personally, and it was a great, great experience. He, of course, as an intensivist, works in the PICU, the Pediatric Intensive Care Unit, and focuses on treating children with vital organ failure, such as lung and heart. So he's going to be talking about prematurity, born too soon, and how does that affect the children. We've talked about the moms, and now we're going to talk about the kid. All right, Dr. Sirigupa, take over.
Right. Thank you so much, Dr. Dillon. So that's the very kind of you, and I do like summers better than winters, so I plan on staying here. So
love it. Perfect.
So let me share my screen real quick. There it is. Oh, shit. All right, so I will try to concentrate on prematurity, and I caught a kind of like tail end of the discussion, and I love the discussion. So hopefully, my goal today is to have that discussion as well, and hopefully I will be able to provide you some materials to start the discussion with, so we can carry on our discussion at the end of this brief talk. Dr. Ladala probably had gone through some of the material that I'm going to present now, but I'm going to start with introducing, like, how soon is too soon, like, what is too soon, and why does it matter at all if the babies are born too soon? And then I will try to give introduction on what are the complications that the baby might have if the baby is born too soon. And overall, like, I think, like, I heard you guys are talking about the grades of each state and each thing, but we'll see, like, how well we are doing with treating the premature babies, and how are we doing as a whole in the state and in the country, and preventing the preterm births themselves. Considered premature. If the babies are born before 28 weeks, they are classified as extreme prematurity, and 28 to 32 weeks as very preterm babies, and the late preterms are 32 to 37 weeks of pregnancy. So why does it matter? As it was probably discussed before, so we almost 10% of the babies that are born in the USA are preterm, and that amounts to almost 450,000 neonates in each year. So 9% of births in California, and they are steadily rising each year. And I think the grade for California is C, if I'm not wrong, on the recent March of Times report. The Fresno, the rate in 2020 seems like around 10% of preterm births. And the other key thing here is the preterm birth rate in Black women is almost 43% more than all other women from other races in California. That speaks to the inequity to the access for care in our state. Almost these premature babies, the extreme premature babies, they have around 30% mortality. That means 30 babies out of 100 don't make it out of the neonatal intensive care unit. And given there are a few medical complications for these preterm babies, as we will discuss, so it also creates a financial burden on the society as a whole. And the looks like as an estimate, like, this is an estimate almost 10 years ago. Societal cost is at 26 billion, and I'm sure it is much higher now. And each child medical cost is around 3,000 to 200,000, depending on the gestational age of the baby. And risk factors briefly, again, I'm sure this was discussed before, maternal age on either ends, less than 16-year-old or greater than 35-year-old. Problems during pregnancy, infection, for sure COVID is a high risk for preterm labor, and maternal factors like anemia, hypertension, diabetes. Maternal smoking is a huge factor as well, and other substance abuse. And twin pregnancies, which are most common in pregnancies that are a result of artificial reproductive therapies, and the maternal past history of premature birth in the mother during the previous pregnancies is also a high risk. And then the other risk factors are congenital anomalies or any especially the congenital heart diseases, etc. And the infection in the baby itself are at a higher will predispose them for a preterm delivery and premature birth. So why does it matter? So this premature deliveries can result in significant medical problems for the baby, and as you all can see here, almost every body system is involved, including the brain. So this is intraventricular hemorrhage, that means the bleeding in the brain. Apnea of prematurity. Apnea means like the babies can't breathe. Sometimes their brains are so immature that they just forget to breathe. So that we call it as apnea of prematurity. And also it can cause long-term learning disabilities as well, because the brain is subject to like a lot of lack of oxygen soon after the baby is born, and other factors. And retinopathy of prematurity, which is a very important factor for blindness in children. Essentially, their retinas don't function well, and hypothermia. They can't maintain their temperature, and a lot of issues with the lungs and their blood as well, because they can have low platelets, they can have anemia and all other factors, and their intestines can be affected as well, which can cause a lot of problems for these babies. And most of these babies are also, at least few of these babies are also born with congenital heart disease, and that can come with its own problems as well. And they have difficulty in maintaining their blood pressure, so they will need a lot of medications, and they can't keep their blood sugar levels at a normal level in their body. This is just a small list, and these babies will need pretty exhaustive intensive care therapies in the neonatal intensive care unit. So I will go through a few of these conditions, like what they go through, and my goal is to give you guys an introduction on, like, few things that we just think that, like, we do it, and these are basics for survival for any human being, and what difficulty that these babies are going to have just because they are born premature. And one of the major things is, like, as soon as the baby is born, the first thing that babies are at a very high risk is something called as hypothermia. Hypothermia is essentially, it's a low body temperature. As human beings, we are warm-blooded animals. That means our temperature is very strictly regulated, and your brain, your blood vessels, your skin, and everything acts together to keep your body temperature at a normal range, like that is around 37 degrees centigrade in our body. And if the temperature is either high or low, our body doesn't work. And that is the reason why the maintenance of temperature is an extremely important basic function for the survival of the human being. And unfortunately, the baby's skin is so immature, and their brains are so immature as well. They can't act together to keep the temperature normal. So essentially, the premature babies act like cold-blooded animals, like, because we have our amphibians, which are frogs and other animals. They don't have to maintain their temperature. They're cold-blooded animals. So they just that's why these babies just tend to lose a lot of temperature. And these babies tend to have large body surface area, especially around the head. Their heads are big. The babies' heads are big, and that is the reason. If you guys have noticed, if anybody is in NICU, or if anybody has been to a baby, has been to a newborn, seen a newborn baby, whenever the baby was born in the hospital, the first thing that our staff do is bring a cap and cover the baby's head. And the reason for that is babies tend to lose a lot of heat through their heads. And they also can't produce heat because their muscles are not well developed in the skin, and they can't shiver, or they can't produce heat. And the hypothermia increases, has a very high risk of death if the baby goes hypothermic for a long period of time after the baby is born. It's also a very high risk factor for bleeding in the brain. And to prevent this, if the baby is after the baby was born prematurely, and this is a very tiny premature baby, and this baby has a breathing tube that the baby that the neonatologist have. The neonatologist is a doctor who takes care of very of these tiny babies. That was put in to help the baby breathe. And as soon as the baby is born, when the obstetricians, which are the doctors who deliver the baby, they hand over the baby to the pediatricians, and they cover the baby immediately in this plastic wrap. And the aim for that is to prevent the baby from losing any heat. So once the baby is stabilized in the delivery room, the baby is brought to the neonatal intensive care unit, and then the baby was placed in something called as, these are like incubators. We call them as isolates or incubators. The aim for that is like these incubators give heat to the baby. It's essentially like a you're holding the baby and giving heat to the baby all the time. And as the baby matures, as the baby is around 35 or 36 weeks of gestation, then the babies tend to develop that ability to maintain their heat, and then they slowly be able to come off this incubator. And the next major system that is affected, or the part that is affected, are the lungs. So I just want to give you all a tiny introduction on the anatomy of the lungs themselves. As you all know, this is the picture of a human being, and we breathe the air, and it passes through different passages here. So through larynx, which is your voice box, and it goes through a big breathing windpipe, which we call it as trachea. And then it goes through just very tiny, small branches of these windpipes. It branches into like millions and millions of tiny windpipes, and they lead into something that is called as alveoli. We call it as alveoli, are something like these alveoli are sacs that will be filled with air, and there will be blood vessels lining this alveoli, and the oxygen slowly diffuses into those blood vessels. And these alveoli are extremely essential part for the gas exchange, we call it as. That means the primary function of the lung is to get the oxygen into the blood and bring out carbon dioxide out from the lungs into the atmosphere. And the alveoli play an extremely essential portion, essential work for that to happen. And can anybody guess, how when does the lung development stop in a baby, when the baby is in the womb? Can anybody guess when will it go on until? So typically, the lung normal development starts almost at 2 weeks of gestation. It goes all the way up to 38 weeks of gestation. And if you all can notice this alveolar, the formation of these tiny little sacs, they don't even start until like 28 weeks of gestation, and it goes on until 38 weeks of gestation. That means if the baby is born anytime before, any premature, like even late premature, they will run at a risk of being born with no sufficient alveoli formed before the baby was born. So essentially, that means that the baby will have a high risk of not be able to breathe after the baby was born. And the other important thing, something called as surfactant, we call it as, and it's a kind of a soap. So imagine this is that one of that alveoli, the sac that we are talking about, and this is usually lined with water. And between these lines, it is supposed to be lined with something called surfactant, which is kind of a soap. and it is just a soapy substance which is made of fat. So what happens is, I'm not sure if you all are familiar with surface tension. So what it does is it decreases the surface tension along the layer of water along the alveoli. So if the surface tension is high, what happens is the alveoli try to keep itself like folded into like very tiny space, so it doesn't want to expand. So what the surfactant does is it kind of decreases the surface tension, so it makes that sac be able to expand better. So that means if you don't have this surfactant, your alveoli, they don't even expand, or they don't even expand. They'll have a lot of difficulty, or you need to push really hard for this this alveoli to be able to expand. So that means the baby, when the baby is born, if this baby doesn't have surfactant, it is very difficult for the baby to be able to breathe. And the surfactant is usually start to produce around 26 weeks of gestation, and it continues to produce develop up until the end of the 38 weeks of up until the birth. So these extreme premature babies, or any premature babies, at a very high risk of this deficiency of the surfactant, and this absence of soap, we call it as RDS, respiratory distress syndrome of newborn. So if you don't have the surfactant, the lungs get collapsed, and there is no way for us to be able to open unless like you either give the surfactant, or you're able to, or you put the baby on a ventilator, and the ventilator tries to force the air into the lungs and expand the lungs. And fortunately, one of the major inventions over the past few decades has been the steroids, the administration of steroids to the mother. And what it does is it kind of stimulates the lungs in the baby to produce this surfactant. And again, this kind of stresses the importance of a prenatal care for a mother. Even if, let's say, if you can't prevent a premature birth, then the doctors will be able to give the steroids to the mother, so the baby will have a smaller risk of developing this very serious disease. And this is a tiny video of like how they give the surfactant. It's not a medication that they give through the veins or anything, and this is the medication that they give into the lungs of the baby. And I'll play this video, and I'll try to talk you all through the administration of surfactant. And the reason why I'm showing this is one of the landmark discoveries in the care of the premature babies, and that has saved millions and millions of babies over the past decades. So let me go back a little more here. So
guidelines when providing surfactant replacement therapy.
Here the baby is born. Now the pediatrician is trying to, this is a laryngoscope blade, and they are trying to look into the mouth and be able to find the vocal cords of the baby to be able to put a breathing tube.
Can you give me a little cry pen?
Yep. How far do we want to be down?
7 to 7. Go ahead.
I'm just putting the adapter on.
And they're putting a tiny adapter to be able to give the medication, the surfactant.
And you can continue bagging.
Mm-hmm.
Where is it? Then we now we're putting the multi-access catheter on. Let me just listen, make sure I didn't do that.
I mean, I could probably put this up now.
Should just take a few minutes, couple of minutes. Shouldn't be too long. You're bagging with 25 over 5.
Mm-hmm.
Nice job.
Right. So we're gonna go down.
Just
and,
keep bagging through the whole time?
Yep. When I actually do it, I'll grab the bag because I'm gonna keep it up. No, let's see what we do.
And what they did was they gave the surfactant, and they're trying to turn the baby around, and they're trying to bag it, kind of like blow the surfactant into the lungs. And the white thing on the syringe is the surfactant, the milkish thing.
Sometimes it backs up. Okay, here goes the half a dose. We're gonna probably run this around, but
Yeah.
old eyes just don't work like they used to.
All right, so a lot of times this work like magic, and it helps the baby's lungs to expand better, and hopefully we don't have to use a lot of pressures to expand baby's lungs. And even keeping the baby on the ventilator, unfortunately, it can act as a two-edged sword, where you're trying to give too much pressure, too much force to open the lungs, and that can damage the lungs themselves as well. All right, and this has a very interesting history too. So as well know, the President Kennedy had a premature baby, and looks like we are not sure exactly how premature the baby is. For some accounts, like the baby was 5 weeks premature or so, 35, 36 weeks premature, and this baby. This baby was unfortunately had this respiratory distress syndrome with surfactant deficiency, and unfortunately, in those days in 1963, the ventilators were not discovered or were not used in the babies for this indication at all, and nobody knew how to use ventilators on a baby. So it was a physician in Canada started to use the ventilators on the babies, but unfortunately they couldn't get a ventilator from Toronto to Boston, where this baby was born, and unfortunately this baby died at around 39 hours of life. And that's when, when a field of neonatology itself was born, because that's when there was a lot of investment in research, and there was a lot of studies that were done, and over the past 5 or 6 decades, we have come a long way to save millions of these babies. But we still have this baby still carries significant risk of death, and they still have long-term morbidity, we call it as. It means long-term diseases in survivors of the premature birth. And so the consequence of what happens in the long term, if the baby makes it out of the neonatal intensive care unit, and they are at a very high risk of a condition called as bronchopulmonary dysplasia, and with the need of ventilator, for a long-term ventilator. And this is a baby with who has something called as tracheostomy here, because this baby or the lungs are not mature enough in this baby yet, that the baby will need a ventilator support for a long period of time, for months and for years sometimes. And that is why, after a few months the baby has been on ventilator, we place something called as tracheostomy. It's a tiny hole that we make on in front of baby's neck, and this is a tiny tube that goes into the windpipe, and we will be able to give air with some pressure, so baby will be able to breathe. Even if they don't need a ventilator, or or this tracheostomy, they are at risk of something called as chronic lung disease, because a lot of these babies, they go out of the neonatal intensive care unit with the oxygen, because their lungs are still not mature enough, so they will need that support of oxygen, and they're at a very high risk of multiple exacerbations, we call it as. That means they tend to get worse periodically. Let's say if the baby has a cold, they tend to get worse, or they tend to have more severe colds than a non-premature baby would otherwise have. So they tend to have a lot of hospitalizations in the future, and they're also at a very high risk for asthma-like conditions. I mean, because their airways, the tiny windpipes I was talking about, they're also not formed properly. So so they're at a very high risk of asthma, and also long-term decrease in lung function as well. And the other major organ that is affected will be is the brain. And unfortunately, when these babies are born, their blood vessels within the brain are very fragile. So they tend to burst open with any sort of like small stimulus that they can have. For example, the hypothermia. That means if the temperature is small, or if they are struggling really hard to breathe, and these babies tend to have these babies tend to have very fragile blood vessels in their brain, and they tend to burst open and causing bleeding in the brain. We call it as intraventricular hemorrhage. And whenever there is a bleeding in the brain, so the brain itself produces some water. We call it as CSF. It produces water, and that CSF need to be constantly drained out of the brain. Otherwise, the brain is going to swell up within the skull, and there is no way for the brain to grow, brain to swell, and that can be a threat to baby's life. So this blood, unfortunately, tends to block up all these tiny, teeny pores within those water spaces within the brain, and this can cause swelling of the brain, which we call it as hydrocephalus. It's essentially the brain will be filled with water. To relieve this, unfortunately, you grade it like, in the severity, grade 1, grade 2, grade 3, and the babies with very severe of this brain bleeding may require, we may have to divert the water from brain somewhere else. So typically we place something called as ventriculoperitoneal shunt. Ventricle means it's a space within the brain filled with water, and the peritoneum means it's the belly, it's a membrane around the belly. And our neurosurgeons usually place a small tiny catheter and a small tiny pipe, and that goes behind the head and through the neck into their belly, and this water will be drained from their brain into the belly, where it gets absorbed. And also, another common thing that happens in these babies' brains is, unfortunately, because they have a lot of difficulty breathing, and they're at risk for hypoxia. That means low oxygen levels in their blood. And the brain needs a lot of oxygen, a lot of glucose. It is very intensive, and it cannot survive more than few minutes without oxygen. And unfortunately, because these babies' lungs are not functioning properly, they tend to suffer from lack of oxygen, and it creates something called as dead tissue around these tiny water spaces around in the brain, which we call it as PVL, periventricular leukomalacia. It's a fancy word, but essentially the white matter around this water sacs in the brain tend to get damaged. And the consequence of that is that those are all very important fibers to control the baby, to control the child's walking, movement, and all those motor movements, and that can get affected, and which we call it as cerebral palsy. And these babies are also at a very high risk for long-term learning disabilities as well. And the other organ that is affected is eye. And as I was mentioning before, this is one of the major causes for visual impairment in children as a whole. Unfortunately, because the baby's lungs were premature, in the past few decades ago, they thought that these babies will respond to too much oxygen, and they tend to put these babies in hyperbaric chamber, or even if they will place these babies on ventilator, we used to give too much oxygen to these babies. But unfortunately, what happens is oxygen. They usually, when the babies are born premature, their blood vessels in the retina are not mature properly, and few blood vessels get damaged. And so at some point, these blood vessels in the retina of the eye, they start to grow again. But if they have too much oxygen, they tend to grow erratically all over the place, and that can cause something called as the retinopathy of prematurity. So that can cause blindness, and the treatment for that is like whenever the babies are in a neonatal ICU, our ophthalmologist will closely watch these babies for any sort of these abnormal blood vessels. And if they find something, they have to go back in and they kind of zap these abnormal blood vessels so they can so the retina can be preserved. So almost like 15% of the babies will have this retinopathy of prematurity. And the lower the gestational age, obviously, the smaller the baby is, and the bigger they are at risk for. And the other major cause of this baby's death, and also this baby's disease process, is the necrotizing enterocolitis, we call it as, because their intestine is another major organ that gets affected in these babies. So essentially, again, like these babies' intestines are not formed properly, and this is a kind of a cross section of the intestine where we are cutting the intestine, and then you're seeing from top, and this is normal. And this is what happens, like, because they get very inflamed, and because they and also I'm not sure if you all know, like, there is a lot of bacteria in the intestines, and these bacteria kind of play an important role in kind of maintaining the healthy to maintain the health of these intestines. And unfortunately, in these babies, those bacteria tend to be not developed properly, or the few of the bad bacteria can also grow in their intestines, and that can all contribute to the inflammation of the intestines in these babies, and they can have huge damage to these intestines. And the other major factor is non-human giving babies non-human milk is another major risk factor for this condition, because let's say, like, cow milk is the most important, most common thing that we use in formulas or other things, and whenever you give the cow's milk, it is from a totally different species, and human beings don't recognize that. Especially the preemie babies can react very abnormally to these foreign proteins from other species, and that can cause this necrotizing enterocolitis. And that is why we stress really stress the importance of breastfeeding in any baby, but especially in these premature babies. And so whenever you have like this necrotizing enterocolitis, you usually tend to manage with antibiotics if it is very small, very not as severe. But in very severe cases, these babies usually need a surgery, so they have to take away these damaged portions of the intestine, as seen in this picture, and then they kind of like attach the healthy portion of the intestines together. But unfortunately, a lot of these babies tend to lose a lot of intestine, almost like 50%, almost 50 to 70% of intestine sometimes, and they are only left with 20-30% of intestine in their body. And unfortunately, you need all that intestine to be able to absorb all the nutrients. And some of these babies, they won't be able to absorb these nutrients when they eat. So this is called a short bowel syndrome. And some babies may not even be able to eat properly, because whatever they eat, they tend to poop it out, and they will have a lot of problems, and they won't even have a lot of nutrients absorbed into their blood. So what we do something called as the total parenteral nutrition. We call it as TPN. So all these babies will have an IV in their arms or on their chest, and they will have nutrition, the food, through their IV. And these babies can get very, very sick when they have this intestine that is as bad as it looks like. They tend to get extremely sick, and then it's a very high risk for death when the babies are in neonatal intensive care unit. All right. So as it's just a small introduction on like major organ systems that are affected, and obviously, like, prevention is always better than cure. It's always better to not have premature birth if at all possible. And these are all the factors that we can do to help prevent premature births, like prenatal care and smoking cessation, prevention of teenage pregnancies, and promotion of breastfeeding. So if you guys know it or not, breastfeeding is the best form, is a good contraceptive. That means like as long as the mother is breastfeeding, there is it is less chance for the mother to get pregnant while mother is breastfeeding, and that can also increasing the interval between the pregnancies can help decrease the incidence of premature births as well, and decrease non-medical indicated induction of labor and cesarean sections. But our obstetricians have strict criteria on when to induce labors and when to do cesarean sections. And the steroids before delivery if premature birth cannot be prevented. And again, like I can't stress the importance of getting prenatal care for each and every pregnancy. All right, how well are we doing? And so I'm sure we talked about this, but overall in the USA, the preterm birth rate in 2020 is around 10.2%, and in California is around 9%. Unfortunately, over the past few years, it has stayed the same or is actually worsening. And the goal in WHO goal by 2025 is to decrease the preterm birth by below 5%. And in fact, USA is one of the worst performing countries amongst the wealthy nations in this world. And one of the reasons why we are doing so bad is probably this health inequity, where like preterm birth rate, especially in California, for example, is much higher in the Black population than in any other population. As I just noted here, like preterm birth rate among Black women is 43% higher than other women. In Fresno, we are at 10%. And fortunately, we do have overall improving mortality next to premature babies. And these days, we are even able to save few 22-week babies as well. And the mortality is steadily decreasing, but not by much. But still, 25% of these babies not end up making it in this world. And another example of these health inequities, and our California is one of the worst states to have this health inequity, and we have a lot of work to do in that sense. All right, and these are the few of the resources that you all can go to and get more information on these premature babies. And that's all I have, and I'll be happy to take any questions and kind of talk about anything you guys want to.
Thank you, Dr. Sirgupta. Thank you for such a great talk. That was really, really well done. I think it was a very good transition from the initial talk to this one. There was some overlap with the data, which is nice. I think it's good to see. And then seeing how it affects the baby, the preterm birth, and what effects it has on their health. There are some questions in Q&A. The first question is asked by Pamela. Was the baby sedated during the surfactant treatment? I think they're referring to the video. Are the babies usually sedated, or what happens?
Yeah, so usually the babies are not sedated when we do that, and it's usually they are not painful procedures to start with, and our intensivists don't tend to give any sedation to be able to put the breathing tube and everything. But usually it is very comfortable. It's not usually painful at all, and the babies usually tolerate it really well.
And I think usually if the baby is unstable, I think that plays a huge role as well as to what they can do and cannot do at that point, how emergent it is and what's going on.
Yeah, absolutely. And it's usually they tend to do the surfactant right after the baby is born. So that's one of the things that they do. These days, they usually even, depending on how the baby is doing, they even take the breathing tube out right away. And a lot of these babies may not even need a ventilator. So, yeah.
Awesome.
Yeah.
The next question is how much surfactant is delivered. I'm guessing it depends until the baby's being properly bagged.
Yeah, usually again, I'm a pediatric intensivist, so I usually take care of these babies once they go out of the NICU. But usually these babies according to their weight, they have a set doses on how much surfactant they get depending on their weight. That's usually the case.
Oh, that's awesome. And then the question was, why is CSF accumulated? Is it an immune response to a severely underdeveloped brain?
So the CSF is usually produced in the brain, and that has to be drained through various ports within the brain. There are usually 4 ports in the brain. And what happens is this blood is, it kind of tends to clot. It kind of produces a lot of inflammation in the brain, and there is usually scar blocking these ports in the brain. And but the brain continues to develop the CSF because it is that is what it is supposed to do. Because those, unfortunately, because of the blood, these ports are blocked. So there is no way for these for the CSF to go anywhere. So it tends to just accumulate in the brain.
Yep, makes sense. There's a question about Valley's poor air quality. So do we see worse outcomes for underdeveloped lungs than other areas of California or US?
Unfortunately, I do not have data on that portion, but we do see a lot of asthma, and definitely, like, I mean, one of the things that we ask whenever the patient is admitted with asthma is like if the baby is premature, because we know that the premature babies tend to have worse lung function and also worse symptoms of asthma.
Yeah. Yep. I think. What's the, I guess you manage them in the pediatric ICU later on after they have graduated from neonatal ICU.
Mm-hmm.
How youngest is the, or how long have you seen a premature baby stay in pediatric ICU after they graduate from neonatal ICU?
Oh, wow. So, I mean, so it depends on the how severe the baby's lungs are injured to start with. I mean, we just had a baby that graduated out right before his second birthday. So, I mean, they can be in the hospital for a long period of time. A lot of times they tend to stay in NICU for how long ever it takes, and sometimes they tend to come to the pediatric ICU because the babies are bigger, and the staff and the hospital and whatever the conditions there, probably like we are better equipped to take care of a bigger baby than neonatal ICU. But yes, it depends on how bad their lungs are. And again, unfortunately, like whenever the baby is born, the reason why we try to get them as soon as we give the surfactant, like, we don't want to put them on the ventilator, is because a ventilator itself can have a lot of adverse effects on the baby's lungs, because you're kind of pushing a lot of air into the lungs, and it kind of stretches the lungs a lot more, and that tend to injure lungs more. So a lot of these babies, it's a kind of a vicious cycle, and these babies tend to have a lot of problems for a long period of time.
Thank you. I think those were the questions that we have so far. We can ask the audience and see if they have any more questions that are popping up. Oh, are there statistical studies on premature babies with cystic fibrosis, or children with cystic fibrosis are solely genetic on defects of lung surfactant?
So cystic fibrosis is a totally different disease, and it's usually their problem is not the production of surfactant. The surfactant is usually totally normal in these patients with cystic fibrosis. The problem in cystic fibrosis is they produce very thick mucus. Because they can't secrete certain things into their mucosal glands, and the mucus that they produce is extremely thick. So these children tend to will have a lot of difficulty in coughing that mucus out, and their mucus is kind of like stuck in the lungs, and that can cause a lot of infections. And that is the problem with cystic fibrosis. And the surfactant, it's essentially like it's not the problem of those alveoli or the sacs I'm talking about. In cystic fibrosis, the problem is in those tiny areas that I was mentioning before. But the surfactant is usually totally normal in these patients with cystic fibrosis. And cystic fibrosis is genetic, yes.
Yeah. Yep. And unfortunately, I mean, we've come far along with cystic fibrosis now. It used to be that they used to not live very long, and now we have patients who are in their 30s and 40s and even longer that they're living. Yeah,
absolutely. And we have a lot of therapies now, and a lot of novel therapies now, including the gene therapies for cystic fibrosis now. So I think these patients are doing much better these days.
Totally, yes. It's amazing how research helps over time.
Yeah, absolutely. And we do have a cystic fibrosis center here, and our pulmonologists are they take excellent care of these patients.
For sure. There's another question about your specialty. Actually, how did you choose your specialty, and did you do your you did your residency in peds and fellowship in pediatric critical care? Thank you for a wonderful and interactive presentation.
Thank you. And yes, so I did do residency in pediatrics, which is 3 years long usually, and the yes fellowship in pediatric critical care, that's another 3 years.
What made you get interested in pediatric critical care?
Oh, so critical care is like essentially it's a physiology. Like, I mean, I was really interested in how body systems work, and critical care is a perfect place to be able to see that in. So let's say, like, if these babies, or if there is a severe infection or anything, like I give a medication or I do something, I can actually see the effects of it right away. And it's always, you think about, like, various interplay of different systems. Like, for example, if you give one medication to help one, for example, lung, it will have other effect on the heart, and how they interplay together. It's very interesting to me. So it's the physiology that I love, and the critical care is the best place to be in.
Oh, yes. I think seeing part of it in the emergency department, at least the beginning of it, totally. It's amazing how all the organs, of course, they're all interdependent on each other, and you do one thing for one thing and you potentially could harm the other one or help the other one. It just depends on what kind of intervention you're doing.
Absolutely. Absolutely. Yeah.
The human body is just amazing. It's very, very great.
Yeah. And why pediatric critical care? I just can't see myself treating adults. That's why I'm in pediatrics. So
I give props to you, kids, because they can't communicate. And I'm like, oh my goodness, tell me what's wrong with you so I can help you. Let's see. There's a question by Dr. Say. It says, are you involved with lung transplant program?
I am not. We are not a transplant center here, and there are a few handful centers in this country, but I'm not involved in lung transplant program here. But when I was training, yes.
In Chicago.
In Chicago and in Florida.
Oh, nice, awesome. Yeah. Okay, yeah, I don't think even UCSM main campus does lung transplant.
No, like Stanford does, and I don't think UCSF main they don't do much. There are very, very handful centers that do a lot. Even in the University of Chicago, we didn't do that many. Northwestern used to do a lot more lung transplants.
Yeah.
And in fact, Northwestern did the first lung transplant for COVID patient as well in this country. But that's pretty cool medicine. It's a totally different medicine in its own right.
Yeah, I think this might be a read my mind question or a very vague question, but now that you've been doing pediatric ICU, critical care for a while, is there one thing that you notice over and over again in intensive care in pediatric population specifically that you think there's a lot of work still needs to be done in that particular category?
Yeah, I think again, like, the major thing is a lot of times we do see patients that come in with again. I always tell people, like, hey, my job is much easier in a critical care here because I know all my patients in my unit are sick and I'll take care of the patients. But the challenging thing is getting this patient, not getting these patients into the ICU in the first place. And that's a huge thing for our pediatricians in the community out there. Let's say, like, to prevent asthma or like to maintain asthma better, like conditions like asthma better, so they don't come into the ICU in the first place. So I think that is a major opportunity for a lot of these families. For example, like a lot of these families that end up in the ICU, the major reason is that either they are not hooked up into a medical system, or they are not using their medications as they are supposed to be, or they are not following it with their doctor as they are supposed to be, and that's why they got into the ICU. And I think, like, that is the major thing that we as a society should be working on, to decrease those inequities and work on access to the healthcare, so we don't we hopefully don't even need to come to the ICU in the first place.
That makes sense. Yeah. Any message for, I think, for the audience that they could potentially share for their new mothers, or for young children in the family, the kids that are newborn or preterm birth? What are the things that, let's say with the winter months coming up, what are the things they need to be careful about, other than COVID, of course?
Again, like, careful. The major thing is, like, hopefully the environment within the home that they are in should be safe, in the sense, like, the smoking is one of the major things that will affect their their lungs and their and also, like, we now even have evidence that, like, if you have smokers in the house, that can put you at a higher risk for asthma or the infections like RSV in these babies. So one thing that anybody can do to help the babies at home is smoking cessation, or, like, preventing exposure to smoke. And a few babies will have allergies, so obviously, like, avoidance of those allergies is one major thing to prevent these exacerbations of asthma or anything like that. And the same thing goes with COVID as well. And COVID is just, again, like, COVID, yes, it's a new virus that is affecting, and it can have some other manifestations of the disease. But at the end of the day, it's a viral infection that is spread through air, and that is spread through other people. So good hand wash is true at any point of time.
Great, thank you. Thank you, Dr. Sergiopa. I think those are all the questions we have so far. Thank you very much for your talk. We really, really appreciate you taking time out of your busy day to come give this talk to our audience. And yeah, I hope you enjoyed it.
Oh yeah, this is awesome. So yeah, I'm up for doing it again. Let me know.
Perfect. I like it. We're gonna try to do 2 sessions every year. We're still working on that plan. So
that's awesome.
Better next year.
Awesome.
Yes. Yep. Thank you. Thank you.
Thank you. Wonderful. Thank you so much, Dr. Sergiopa. That was excellent. And
thank you so much
to both of our wonderful speakers. We hope you all enjoyed them today. I know I learned a lot. I'm sure you all did too. Please come back for our last session next week. It's going to be a fun one. We're going to have Dr. Kenny Bond. He's going to talk about some of the COVID outreach he's done, vaccine efforts that have been happening in Fresno. He's really been kind of spearheading all of that. And we will also have a very fun panel with the SJV Prime students and kind of hear about their journeys to medical school. So we hope you all can make it. And I hope everyone has a great week, great weekend. And thanks so much for joining Mini Med School. Suki, anything before we take off?
I think we're good. Yeah. Thank you, everybody, for joining us late in the evening, and we'll see you next week for closing.
Thank you.
Thanks, everyone.
Thank you. Bye.